Uh, we will be beginning in the next 1 minute. Before that, I would like to briefly check the mic and video of the panelists that have joined us. Ms. Abha, could you please identify yourself? Ms. Abha, am I audible to you?
Yeah, sorry, I was just on the phone call. Thank you.
No problem. Thank you, loud and clear, and your video is great as well. Thanks. Ms. Hegel, I hope I'm saying your name right. Could you identify yourself?
Yes, hi, Jim.
Hi, Jill. Okay, great. Your mic. Could you just say something? I couldn't hear you.
Is it better now?
Yeah, much better. Thank you so much.
Oh.
Thank you. Ms. Maya, could you please identify yourself?
Hi, this is Maya.
Thank you, ma'am.
Can you hear me? This is Maya. Yeah.
We can hear you. Mr. Ali, can you identify yourself?
Yes, ma'am. Am I audible?
Yes, you're audible. Has Professor Santosh joined?
Ma'am, he is just joining in a minute or two. I just
okay. Okay, sure. So he'll be here in a minute or two, right?
Yes, ma'am. Yes, ma'am. He's in a
Great.
process.
3 p.m. maybe we can just start on with the introductions and Professor Santosh can join us then. Siljo, would you like to take over from here, please?
Thank you so much, Valerie, for this. So once again, I would like to just welcome all the panelists and especially all the participants who have joined us for this very important COVID-19 Academy session, which we have planned today on the topic COVID community-based initiatives for COVID-19 response. I would like to briefly welcome all the panelists who have joined us. I will just give a brief intro about all of them. Firstly, we have Professor Santosh Kumar, who is the professor and head governance, policy and planning and inclusive DRR from NIDM. Professor Santosh has a vast experience of 25 years in different positions in development planning and DRR sector. He is a PhD in economics. He studied gender and development in IDS, Sussex, UK, and received professional training in disaster risk management from Israel, back with international work exposure at the World Bank and intergovernment body of SAR. He has also worked at the state levels in different capacities in UP Academy of Administration, Nainital, and RIPA. He's an experienced hand in designing, planning, and implementing mitigation and long-term disaster recovery plans and projects. I would like to welcome Professor Santosh once again. Next up, we have Prushti sir with us, Mr. N.M. Prushti, who is the Mentor Director, CDMASS, and also the President of Humanitarian Aid International. He is also the board chair for Vision Spring India. Prushti sir has been in this sector working in the cutting edge areas of development management, disaster management, climate change, institutional development, policy and program analysis and design, training and capacity building, leadership development, mentoring, incubating, innovation, promoting people-centric collaboration actions among stakeholders. I welcome you, Prushti sir. We also have today with us Ms. Abha Mishra, who is the head of officer UNDP Odisha. Abha Mishra is the head of office. She has over 28 years of experience in project management, advocacy, action-based research, and implementation of national and community level development projects. Ms. Haba has done her MSc in development anthropology. She has worked with several NGOs and international universities like University of Frankfurt, Germany, University of Edinburgh, Scotland, and University of Greenwich, London. We welcome you, Ms. Abha. We are also joined by Dr. Maya Mascarenas, who is the program officer from MIRADA. Dr. Maya is a pediatrician and community health specialist by profession, having trained and worked at St. John's Medical College for over 15 years. She has spent the past 18 years with MIRADA, an NGO focused on integrated rural development. Over the years, she has worked extensively in North and Central Karnataka and other remote areas of Chamarajnagar and Kolar to develop sustainable community models to address anemia, malnutrition, etc. in women and children. Last but not the least, we have been joined by Ms. Hazel D'Souza, who is the program executive from Basic Healthcare Services. Hazel is an executive program at Basic Healthcare Services. She currently leads the quality assurance of health services, oversees health programs at Amrit Clinics, capacity building for community health workers, and supports the community engagement and participation initiative. Hazel previously worked on application of technology in health and e-learning portal for doctors and mobile-based application for health awareness in pregnant women. She holds a bachelor in health information and administration from Manipal University. We today for the session we have the moderator Ms. Valerie Agarwal, who is the program manager of Spare India. Ms. Valerie is an humanitarian professional with more than 5 years of national and international experience across 10 Indian states and 2 countries in disaster management, emergency capacity building, multi-stakeholder project management, and community organization. She has an academic background of economics, social work, and international humanitarian law. So this is the set of vast panelists we are having who are from various sectors, experts in their own fields. We are really glad to have you all in the board. So I really look forward to having this session, and I hand it over to Ms. Valerie to take this panel discussion forward. Over to you, Valerie.
Thank you very much, Siljo, for those introductions. Before I go ahead, Ali, just please let Siljo know when Professor Santosh joins so that we can make him the co-host and go ahead with the questions for him whenever he joins. Right, with that, we begin today's session on community-based initiatives for COVID-19 response. Community engagement has, it has been seen as critical in many health initiatives globally, and it was, like for example, it was considered very fundamental component of an outbreak such as Ebola. So community-based responses have been very important in management of COVID-19 in India as well. They are the first responders to disasters and emergencies, as we know. And leveraging the strength of these communities can really help mitigate the impact of any disaster. So this session aims to highlight the role of community-based initiatives in mitigating the impacts of COVID-19 in India. So we'll also try and cover the initiatives that have been taken by different stakeholders for the COVID-19 response. With that introduction, I would like to basically start with the very root of this question. I may come to Mr. N.M. Prusti with this. Sir, can you help us understand that what is the importance of community-based initiatives today in the context of the second wave of COVID-19 pandemic? And while you do that, maybe you can also help us understand about the CBCP model, which is the community-based COVID prevention model for containment of COVID-19 in India. Thank you, sir.
Thank you, Valerie. Do I start now, or do I start after Santosh makes the introduction?
No, sir, I think you may start. Professor Santosh has not joined us. You may please go ahead with the panel.
Okay. Thank you very much. It's an excellent occasion that we are talking about the importance of communities and community initiatives, community-led actions to deal with the COVID pandemic. In India has been the birthplace of the famous CBDP, COVID community-based disaster preparedness, and we have the privilege of hosting the world's largest community-based disaster preparedness program. It was conceptualized in this country, it was built in this country, and it was scaled up in this country, and it created a demonstrative good practice. Now here is a situation where in another form of disaster, which is quite huge and complex, and affecting all strata of the society and posing a tremendous challenge on our system as a whole. Today, you know that the entire governance system is completely busy with the management of COVID, and rightly so, because it has attained that kind of scale. While doing this, we have used to talk that in CBDP, the community is at the center of all interventions, and community is the first fast responder, Raj, you have made in your introductory statement, Valerie. How we use that experience to deal with COVID. In the first wave of COVID, it was confined to the urban population by and large, because it is a disease which came from abroad, and it's started touching the elites and the better part of the society, and then gradually it's traveled from the top of the pyramid to the base of the pyramid. And during the first wave, there was enough discussion, and there are a lot of concern that we should try our best to prevent community spread. And in fact, WHO was also very clearly signaling that everybody should make efforts to stop the community spread. And in India, we tried our best to prevent community spread. But today, in the first safe wave, the second wave, I think there is no denial to the fact that we are in the community spread mode. And it has gone to the rural hinterland. It is touching the most remote pockets, the tribal pockets, and the most vulnerable pockets. It is to be dealt in that context. So therefore, I think the importance of community coming into the center stage of action is very, very important. So on this background, I like to share some of the things that how we can look at this community-based COVID preparedness. When we say COVID preparedness, we are talking about COVID safe communities, COVID safe workplace, COVID safe. When we say COVID safe workplace, I'm talking about all the frontliners who work in this area to pursue their work, like the health worker, the police, the sanitation worker, the livelihood promoters, the service providers, you name anybody, they are the front line. And then the NGOs, the civil society organizations, the community groups, the women self-help groups, they are also the part of the front line in my definition of frontline actors. So how we deal with that? So I'm taking the cue from CBDB. Many of you gathered here today, especially Abha, been very proficient in managing CBDP in this country and leading the CBDP process in various parts of this country. So I'll expect that if I have missed something or have misinterpreted anything, they will be able to correct and amend and make some suggestions. So I've got 15 points for describing this CBCP approach. This is the first one is the risk information. We always say in our disaster management protocol that we have to make the stakeholders appropriately risk informed. The community is a very important stakeholder, so we have to tell them, we have to inform them how what is the risk of COVID and what is the risk of COVID to the other stakeholders, like who are providing services to the communities and all that, like meaning service provider, who gives you vegetable, who gives you milk, who gives you sanitation service, who gives you household support services, who gives you laundry services, gives you the hair cutting services, who gives you tea, who repairs your vehicles, who carries you in the rickshaws. These are all service providers, and they are truly the frontline workers. They're not organized sector, they're informal sector frontline workers. So how they are informed in the best possible way about the COVID risks. This is the part one. And then part two is this COVID appropriate behavior. Having informed and then to deal with COVID, we need to understand COVID appropriate behavior, which has been extensively discussed. A lot of protocols are being developed, guidelines have been developed by the Ministry of Health and Family Welfare, WHO, UNICEF, and name any organization. They have done excellent work, and there are a lot of display information, IC material also available on that. But how this the CAB, COVID appropriate behavior, informations or the protocols, how it can reach to people and how they can put it to practice and all that. If we make an assumption that it has been developed and given by sent by email to hundreds and thousands of NGOs and it will automatically go to the last mile, that's, in my opinion, is not a very fair assumption. So we have to make very serious efforts to make sure that this thing really travel to the last mile, and how it can travel in a very complex situation like this COVID situation, where we're talking of no contact services and restricted traveling and restricted interfacing. So all these limitations are there. So what we have to be innovative and be very constructive and appropriate, that we promote the community, the COVID appropriate behavior. Then the third part is the early detection. Having understood the risk associated with it, that still we are likely to get affected. So what are the kind of symptomatic and asymptomatic signals for detection? And when we detect, that is the time the trauma starts. Because there is so much of fear that this is such a dangerous disease that if I get affected, I might die. It can happen so fast and all that. The chances of cure is so poor. That kind of presumptions are there. So that, how do you deal with that trauma situation? And then there is also a issue of stigmatization. Like a lot of people, even if they get affected by COVID, they try to hide it and all that. It is exactly the same way as it was happening in HIV/AIDS and all that. So how we can make sure that there is nothing to hide about it, and that stage trauma management is also necessary. So early detection is a very important phase, because the earlier you detect it, or better you can manage it. That is the.
So if I may come in for a minute, what I also want to bring to the notice of the panelists is that since this is like a panel discussion, please feel free to supplement whatever Pushti sir is saying. And sir, if I'm so sorry for this, but since we are having a constraint of time, if you could just wrap this part up in the next 3-4 minutes, then we will move on to the next panelist as well. Thank you, and
Okay. I'm sorry, probably I was late taking more time, but I'm on the third point, but another 12 points, but I'll be very fast. The fourth point is that domiciliary treatment. The analysis has indicated, the evidence are there, that 85 to 90% of the COVID patients can be treated at the household level. They did not go to a rush to the hospital. So that is a domiciliary treatment. So we have domiciliary treatment protocols, and how during the domiciliary treatment they can have access to various services. And services include many things like teleconsultation, diagnostics, medicine, food, ambulance, you name anything, that those are the services. So then options, methods to access those services. What are the modalities and the processes? Then sixth point, the local level resources and methods and approaches to pool, mobilize these resources include volunteers, COVID kit, transportation, stretcher, oxygen, isolation centers, doorstep testing, doorstep delivery, vaccination, psychosocial counseling. All these are the kind of examples of various kind of services which has to be localized. And that is the 6 point. 7 point is that how do we do this? This is well said and done, but what are the kind of timeline? Because the COVID, the lifespan, the moment COVID attacks a patient, I think the most critical period is if you are handling about in the first 4, 5, 7 days, it is better, and then if it stretches, then it becomes difficult, and all that. Those span is almost about 2 to 3 weeks time. So our action time therefore has to be so smart and prompt that we will have to, in this 2 to 3 weeks time, we're able to be very focused manner, we are attentive to that COVID affected person. So access to clinical service, then comes the clinical services. So what my point is that just before the patient goes to the hospital, there's a whole lot of services I talked of. Those things are a bit of non-clinical or semi-clinical in nature. So and those are the kind of things that community can very well do, and the community organization, civil society organization can do it very well based on our experience of dealing with various disasters, especially having learned the tools and skills CBDP. And then the eighth point is that the ninth point is the monitoring the patient condition. When patient goes through this the pre-clinical stage and during the hospitalization stage, how the conditions are monitored, the information are provided to the families, and the informations are also provided to the state dashboard and all that. And then in the event of the patient dies, how do we move the dead bodies? Those are creating a lot of problems. You have seen in the media now, that transportation and movement and managing the dead bodies, and how can you provide dignified cremation to the dead, and restraints in post-death rites, how we can be very dignified in the post-death rituals, and that is the time when we need a lot of counseling, and there's something called bereaved management. Managing the bereaved is important, and honoring the dead, and allowing the affected families of the dead to release their anguish, release their pain and strain, so that they'll be able to deal with the trauma. So these are some of the fundamentals of the psychosocial counseling. And then the 14th point is that how do we create a dashboard where all this information that we talked step by step, all these are also available for public information and the information of the public system, the government and all that. Because the information, the data is important for making analysis and creating models. And then finally, everything can happen not in isolation, but in collaboration and coordination with other stakeholders. And more importantly, when we're talking of the rural hinterland, it is necessary that we align with the panchayats, the blocks and district level very, very intimately. The government has been facilitating, creating the district level, state level coordination. We have to go down below still to the block and panchayat level. And panchayat institutions are having little weak management processes and management capabilities. So therefore, the civil society organization can really supplement bringing in this kind of management capabilities by working with the panchayats. So these are some of my points, and now I leave it to the other panelists to comment and the participant also to comment. I'll be happy to respond to any of the reactions. These are the framework. We have to work hard on converting into a program design and program model. This is the whole purpose of introducing the idea to all of you. Thank you.
Thank you so much, sir. That was really informative. I'm going to move to Santosh, sir, with my next question. So like we know, community is the first responder in any type of emergency. So when we talk about community involvement, especially in the context of COVID-19, are there any guidelines set for this sort of a community involvement?
It's a good question, because COVID-19 is altogether very, very complex and different. If you open your WhatsApp, and you will find that thousands of doctors, thousands of advisors, thousands of kind of a source material which is coming to your this phone. And now as a affected party and also as a service provider, you get confused. What is to be, how to filter out this for the community guidelines. So many things are coming at one go. And then crisis is also that X is good or Y is good. One that is very challenging is that when we talk about community-based response, and here we are talking about how community can help, which has helped in COVID-19. But the challenge is that here you can't work together and can't interface with the person whom you are giving the service. The touch is gone forever, because we say that 90% healing happens when you give the touch to the affected person, of any person who is suffering with any other ailment than the COVID-19. So this is one challenge in drafting that how, like suppose you wish to give a food material to the person concerned, and those all people are whole family is affected. One person is affected and family is outside the state or the city or the country. Some is aged person and some is a different kind of a. So how to provide that food to them, whether the community service, we see that during this COVID-19, many of the organizations came forward in the WhatsApp message that you call this number and you get the food at this much a price, so no exploitation. At least those community-based organizations, at least they are behaving sensibly and supporting that. But market is behaving very differently this time. There's a lot of hoarding. Market is exploiting the situation, exploiting the grief of the people, exploiting the shortages of the services. So that how that market people who are running and controlling the market should be sensitized by the community worker, by the regulation of the government. That is very, very important. Whether you talk about remdesivir or talking about oxygen, or whether talking about oximeter or talking about smaller, you will find any person who comes on the television said D2 is very important drug, and tomorrow morning you will find that D2 is out of the market. Why this is happening? So here that how the community pressure can actually help in bringing those, when the guidelines community in group like Mr. Prusti was telling, from risk assessment to informing to services to supply chain to everything. So how that community will make sure that you should not get affected, and also that service continue to the needy. That is the most important. But service will reach only when it is available in the market. So if that availability is not there, then how come that community? So the guidelines, when you are talking about the community guidelines, is the only thing which we say at this point of time. Although that NDMA guidelines is there for other disaster, pandemic guidelines one or the after is coming, that how to behave as an appropriate behavior. So those are the guidelines in which we are finding innovative solutions, that how we should go. And whether like this time people started looking at the oxygen concentrator every house, like in my society, when this peak came, and we got, everyone was into kind of a trauma, and they were anticipating. Worry was the anticipation of the disease. You are not affected, but the anticipation of the disease making you worrisome. So there we said that how every society can become self-sustainable more than so our society and RWA, we requested many of the RWA, they have set up their own kind of a system. They have a concentrator, they have an oxygen cylinder, they have a 5 to 6 bed, so that the pressure on the health. But the concern which I'm trying to make is, I say that 90% of the people can be treated at home. So even if we take the data of 4 lakh per day per person, per affected rate is 4 lakh every day. Then I was looking at this, only 40,000 people require treatment at the hospital per day. So, and India is a pan-India data. Because 90% can be recovered. So how that community institutions or the with the government, with the health service providers, with the ICMR or other institutions responsible for, can communicate to the people that don't get worried, and 40,000 is the only pressure which we have to handle. And that 40,000, 90% we can educate them how in the first week of the affected people can start working. The itself is a hospital. Household has become a hospital these days. So that is the thing which to be looked into. Now the one thing which I would mention here, what Mr. Prusti said about the rural issues. Urban somehow, and after losing so many lives, we are now getting equipped with the supply of the oxygen and also the beds, and everywhere it is happening. But the challenges for the civil society, again with the kind of a cascading effect, like we had cyclone, and this cyclonic storm and the COVID appropriate behavior, and in the that is also to be looked into. While pandemic time, the other disaster will also happen because of the exposure of India. So we should not, we should think of planning when we are talking about that, account for that other disasters as well. So when it comes to that overall guidelines of the community, how to give this kind of a services to the people at the time of pandemic is a very, very challenging, and I would say that community will evolve. It has evolved, and also they have brought some many innovation during the wide. We did not know the kind of a one innovation. The langar, we used to know only food langar, but now we have oxygen langar, where we have a medicine langar. So all these community innovations which have come up because of the pandemic 19. So many of such kind of ideas, people are like, no RWA had this concentrator on medicines for the emergency, but now they are having this to fight out pandemic and heart attack ailment kind of a thing. where concentrator and oxygen. So this is also becoming a kind of a self kind of a community preparedness, where the RWA community level they are preparing. And another, I found that there's a concentrator bank where somebody has brought 20 or 30 concentrator, and they have put out the information, this is the bank, whosoever is needy, they can take all these community initiatives. So what I'm saying is community has also, they are also evolving, community-based institutions, they are evolving. Those who were not into social service, they have swung into action and also trying to help the people. So it will evolve, and maybe the second wave, once it is clear, then for the third wave, certain guidelines, people themselves will evolve the third guidelines that how to take on. Not necessarily we wait for the government to have the guidelines, and it is people's guideline would be there, and government is always there to kind of support such initiative, work together and take this agenda forward.
Thank you so much, sir. Building on to that, I'm going to move to Ms. Abha Mishra with the next question. Like we've learned, like in this response, also the community is evolving. We are seeing things that are happening day to day, and then also as we move on, we are seeing what can be done. Communities are also identifying what are the gaps and where they can fill in. But when we talk about the idea and importance of community resilience during emergencies, can you comment, like nationally and internationally, is there enough recognition to community resilience, and how can community resilience be further strengthened in the context of COVID-19?
Thank you, Valerie. As far as if we look at what steps the state government of Orissa has taken, or the state government or the national government has taken, and also a lot of examples which is coming from internationally, people have recognized and are recognizing that community participation is very much there. Specifically, if I take the case of Orissa, even before the national lockdown was declared, we had already declared it. There were a lot of steps where the NGOs were being involved. Similarly, if you look at it, the panchayats were empowered, and they were not empowered as we commonly understand, but also the given collectors power to take up a lot of activities. They were given to monitor the food material which is being distributed, that what is happening in terms of the temporary medical centers which were there. They were also the masks and the sanitizers which were the women SIG groups were coming in. And that is one thing which we have heard all across the country. The women SIG groups have been very, very involved in that. And the ASHA and ANMs and the Anganwadi workers were supported amply by all these women SIG groups as well as the elected representatives. Having said that, I think we still need to go a long way, specifically in country like India. There were some countries where you have a voluntary system, you have a management protocols laid on how to engage NGOs, how to engage volunteers, how to engage small groups. But I still feel that in India, we still haven't been able to have that as a national policy. Some states may be doing well. If you really look at it in terms of Orissa, we have done quite well in that particular sense. And our response to various disasters have taught us the importance of community engagement. And similarly, the case could be for Kerala. Kerala has a very, very strong sense, but many of them put it across because of the communist leanings. But if you look at the Northeast, you find exemplary examples from there. You know that there are stories where the communities have actually built shelters outside their own villages to house anyone who has tested COVID positive, rather than sending them into a hospital, or keeping them in a home isolation, which may result in a new case within that household. And even the distribution mechanism which was adopted by many of the northeastern states communities were very it was with dignity you are accepting that relief material. In the second situation, but somewhere we are also not being able to take it up, because even if we give the powers, there have been certain instances where the powers have been either misused by the community members, or they have been abused for using the powers given. So I think as a nation, we still need to have more protocols, and also a lot of capacity building to understand what community based approaches are. We still somewhere are missing that particular point. One more thing which is being there, which was quite well demonstrated by the government of Orissa, was funds, material, and resources. All three was made available to the community. You may give the community the powers and also engage them, but like, you know, as of now, Niti Aayog has said, oh, let us engage thousands of NGOs across the country, community based organization. But what are we giving them? Because somewhere they have to have resources of all these type.
Thank you so much for that, ma'am. Like I said, if anybody wants to add to that, please feel free to do that. I would like to pose my next question to Dr. Maya. So, Dr. Maya, in context of COVID-19, can you help us understand also the role of MyRADA and maybe personal examples from the organization about what are the community-based initiatives that have taken place? That is one. And second, can the involvement of the volunteers that are present at the community level be streamlined for effective response also being done by other stakeholders? Like, how can we involve community volunteers in that? So that's my question to you. Thank you.
Thanks a lot, Valerie. I'd like to take off from Abba's point actually of engaging the community and making sure that they have the resources to do so. I mean, you just can't do things out of the air, and very often that's not recognized by a lot of people. In the urban area, like Dr. Santosh said, quite a lot was done because of CSR funding and a lot of other people bringing in their own personal money into it. But my experience is largely rural based, and that's the whole. I think the whole rural area has not been even thought of seriously, And in the first wave, it was all largely focused on the in-migration, all the migrants coming back and then bringing the illness in. But this second wave has actually every single district where we work in, COVID has left quite a bad impact in terms of the numbers of cases, and it's just rising. And contrary to the urban areas, there isn't any kind of facility in the rural areas to take care of people who have COVID. And I think the Northeast is an exemplary example and many places have done that in villages and even the north of Karnataka and Gulbarga and Bidar and all where we work, where they've looked at a community hall or some other place where, because somebody cannot isolate in their own home, which is just a small or 2 rooms or something, they put them in a different place. But that again is largely the response of that local community, the SHGs, and maybe an interested panchayat member, but not because of a planned guideline or set of responses, put up by the district or any other. But I think we need to take these initiatives forward, going forward, that COVID is not about oxygen only. Okay, and the community's role is, you have to look at the prevention of COVID. We're talking about a third wave coming up. We're talking about the second wave ending, first of all. It's going to probably end in the urban areas, but it's going to extend in the rural areas now. And what can the community do for prevention? The whole idea of like SHGs making masks, they have never understood social distancing. I think it's a wrong word. It should have been physical distancing. And that's largely been ignored, and just said, oh, this can't happen. It can happen if you plan it. And the area of post COVID, many people think, okay, you get the illness, you isolate, 20 14 days and something, and then you're fine, and then you're forgotten about. And we, as a doctor and as a person working with such a lot of COVID, the post-COVID complications, the post-COVID trauma, the mental health issues are something that we also think the community, can help to support in a large area. So I think areas, community-based initiatives can focus on the nutrition support, which they've done in an excellent way in the urban areas. They've really reached out, and in the SHGs in the rural areas have done that for many times in many other illnesses, especially HIV/AIDS area. So that can be something that can really help. Transport facilities for those who do need to reach up, because the closest place that could respond to COVID is the PHC if they get those oxygen concentrators. I'm talking about someone who needs, more than home care. Then vaccination. We haven't spoken about vaccination, and I don't think it has reached. I mean, there is a gap now, but we can plan to make sure that there is some push for vaccination, because finally that is the only true prevention, at least of severe COVID illness and deaths. So we are struggling with the number of deaths this whole second wave, which could have been avoided if we had the vaccination. But moving forward, the community can really move for a vaccination drive, just like they had pulse polio. They can have drives that are similar for the COVID vaccination, planned from the district downwards. And I think that's something we have to start immediately planning for, because we can't wait for the vaccine to come and then start planning. And awareness, I'm really worried, because we've already, in Karnataka, we have 40,000 children who have been infected, and those numbers are underreported, I can tell you, because I'm treating, if one member of the family is COVID positive, I can give it to you in writing that the rest of the family is going to be COVID positive in the week, because it's a very virulent strain this time. And the third wave, we already predicted that it's going to affect children a lot more. It's going to infect children and affect children. We're already having so many orphan children now, because both parents have died of COVID. So we have to develop some community-based response to address children's safety, children's health. How can we prevent them? We don't have a vaccine for them as yet, and we can't really expect them to social distance, and the whole effect of lack of schooling. There's so many mental health issues that they're going to be having. So I think the community response is there, and that's what we are starting to develop now in our districts. We have SHGs and we have farmer groups, and we find those two very, very strong groups there, and the panchayats can be used to a large extent.
Thank you so much, ma'am. Yes, Ms. Abha, you would like to add? Your microphone will need to be unmuted.
Sorry, it got. Yeah. No, what I was just saying that, what Maya just said is very, very important. And I think in the first phase, the government of Orissa actually took that into account. And a lot of the food materials, not only dry rations, but even cooked food, was made a community level initiative where SAGs and panchayats and others were involved. Even the mask distribution, as of now, they have taken a decision of procuring mask and distributing all across, and specifically to the poorest of the poor. And they are doing it through the SIGs and through the community level And even the vegetable vending and other things during the lockdown was actually given it to the SIGs.
Yeah.
So there were many places, new vehicles were bought in so that the SIGs could take it across to far reached away places where traders were not allowed to go and all those. So the SIGs were there. And most of the social sector schemes were augmented through the SIGs. Most of them got the pension amounts and the food materials, even equipments, medicines which were to be there through the SIGs. So I think it is very important to the point here which I was also, and I think Maya is also making, is also somewhere we need to institutionalize it.
Yeah.
It should not be just a one-off event, because in the first way we did it, then because there was a null period, we dismantled the whole thing, and all of a sudden again we have to do it. We have been just through a 15 days partial lockdown and shutdowns at the weekends. We again extended for 15 days, and we don't know what is going to happen after that 15 days. So community based organization and NGOs, somewhere in the whole gamut, somewhere we are missing these NGOs and the voluntary organization like NYKS and NSS.
Yeah.
Some people are using them, but not everybody. So that's something which we need to collectively think, how do we take it forward, because they are very, very important for community based preparedness
I totally
and
agree, and
response.
there is a win-win, approach here. At least, which, and you're right to say in the first wave we actually did it, to allow for the nutrition food in some states. The win-win approach for community, organization CBOs is that it's like making masks and food. Is there some socio-economic activity also? Because remember, there's a huge economic fallout also from this whole COVID, pandemic. So I think we have to capitalize on that, and I think Abbas right, and institutionalize it and make it, a proper set of policy guidelines going forward. And one more question was about training. Yes, training is absolutely critical, and at least currently there still hasn't been formal training of the ASHAs, ANMs, etc. on COVID. I know because I'm part of the capacity building team at the center, and today currently there's a meeting going on to plan that, so we're already quite late in it. I think we just have to train volunteers on how to deal with it.
I think Sphere should take a case study and do what Orissa did, because Maya, just to let you know, all ASHA workers, ANMs,
Yeah, so
the elected representative were trained across Orissa by WHO team, UNICEF team,
yeah,
and the health department themselves.
very good.
So
Yeah,
that went off very well, and I
very
think
good.
that's one of the reasons why we literally, even today, the ASHA workers are going and starting a door-to-door campaigning on masks and
Okay.
other things, and to also find out if there are COVID. I mean, there's some symptoms and other things. So a door-to-door campaigning is starting in rural areas in Orissa.
Thank you so much for that,
So
Ms. Abha and Ms. Maya. I would
Good.
like to move with my next question to Haijil. Building up on what Ms. Maya and Ms. Abha also have said in terms of there is more involvement required also from NYKS or civil defense for this. When you talk about it in the context of Rajasthan, how have community volunteers or community as a whole supported the COVID-19 response, especially with the focus on healthcare, since that is your specialization? Thank you.
Yeah, so thanks, Valerie. So I'd like to just start a bit about the context of that we work with in Rajasthan. I have more experience in the rural aspect of it. So the community that we work with is highly dependent on migration. Most of them migrate to Gujarat, Maharashtra. They the area, it's like most of the community is tribal, predominantly tribal, and the area is inaccessible. It's very hilly terrain. So this comes with its already with a set of challenges. And when we speak about the healthcare system over here, there are PHCs at 25,000. There are sub centers at 5,000. But as it is in many parts of the country, many of them are shut throughout the month, or there would not be a doctor here. If someone comes here for a delivery, sometimes even when the case could be managed at the PHC, they are referred ahead, and this has led to a lot of mistrust on the public health system. In normal times, this mistrust is there, but at times of in a pandemic, when we really are trying to build community awareness, trying to influence behaviors, this kind of mistrust is impeding the kind of response that we want for COVID-19. So this is the system that we have, and what I would say right now with vulnerable groups, especially migrants are a vulnerable group, pregnant women, children, elderlies. We haven't spoken a lot about the elderly population. This is a group that faces an additional set of challenges during COVID-19. And from what I can say from the field here is that the lockdown and closure of transport services has really impeded their access to healthcare. Many of them who are diabetics or who are asthmatics, the persons with HIV, who would be able to access their medicines at the block or at the PHC, are now unable to do so. And this is what we are seeing among the elderlies. In pregnant there's a lot of fear about going to the public health system, like I said, because of the mistrust, and not everyone is going there for a checkup. There's this fear about the vaccine, that vaccine hesitancy, that if we go there we will be injected with the vaccine without our consent, and that will result in us dying. So because of this, a lot of pregnant women are not accessing care. They're not going for their regular checkups. So this is the kind of challenge that we are facing here. And what I can say from our experience is that we have we thought about this, and especially with COVID-19, it has now spread across in all our communities. So in the past few weeks, starting in early May, we were able to build a network of volunteers. This is from our own existing volunteers, and we also partnered with a lot of NGOs here, civil society here, and now we have a huge group of volunteers who are working along with the ashas, along with the Anganwadi workers, because we see that a lot of people are not, they're not telling them about their symptoms. If they are sick, they are not telling the ANM that they are sick. Just an example from this week, it's a primary healthcare center that we run in partnership with the government of Rajasthan. There was a pregnant woman who had symptoms of COVID, but she did not inform the ANM, and over certain 2-3 days those symptoms worsened, and at that time, because she had no contact with ENM, she went to different places, and finally she went to the district hospital, but by the time she could not be saved. So this kind of trust building, I feel the community volunteers and community organizations can help with it at this time. Another way is decentralizing care. We all spoke about home isolation. We spoke about home-based care. How a lot of those who are affected with COVID-19 do not need hospitalization. And we're seeing here how community volunteers are helping with that. They're going door to door. They are, along with giving medicines, they are also counseling people for home isolation. That is context specific. So understanding that here they cannot stay in a separate room, but then uh, because of that, they are now counseling them for isolation outdoors. That is, here many people have fields, farms. They are able to move into the angan outside. So keeping the messaging context specific, and also helping them isolate. So in places where 3-4 people are sick in the family, and probably they are unable to go ahead and get their ration, or they are unable to fill water from the common hand pump, how our community volunteers are then helping them, getting the community together to help them in these tasks. This is another example from Rajasthan. Another thing was for referral. So Dr. Maya spoke about persons who require advanced care. They cannot be managed at home. And here the community has actually come forward to help them transport these persons from their home to the nearest facility. So this system was in place before COVID-19, because we do have a lot of home deliveries happening here. And we had already spoken to many taxi drivers, cab drivers here uh, to help them to bring patients bring women who are in labor to the hospital. And during this time, this network really helped, and we were able to get more taxi drivers on this network. And now they've also reduced their rates, understanding the system, understanding the current scenario. So the community-based the community is really helping in also transporting people. And so a new group that has emerged are the youth. There are a lot of youth in the villages who are educated, who are in different professions, teachers, some are nurses, and they understand. They also are kind of a medium between the information that is coming through WhatsApp, through YouTube, through newspapers, and there this link between communication and the villagers and the rural population, because not a lot of villagers here are able to read the newspapers. So the youth have really come together here. One example that I can think of is because a lot of people are dependent on unqualified providers, on quacks, for seeking care at other times. We're seeing at this time some quacks have tested positive for COVID, but they're still roaming around in the villages and probably spreading the virus further during home visits. And the youth have come together to they've come to stop this, and they have really informed people that this is not right, and we're seeing that change. So the youth are also a really important aspect of community participation.
Right. Thank you so much, Haider. I think you clearly brought out the ways in which community has been supporting the response in Rajasthan, whether it is trust building or decentralizing care, messaging with people, helping with isolation, and also transportation and the involvement of youth. So that is great. I am also going to go back to what we were discussing with Ms. Abha and Ms. Maya about the capacity building and training of these volunteers. So I'm going to ask this question to Prushti, sir. Sir, in the current context of COVID-19, with all the restrictions that we have, how can capacity building of frontline workers and volunteers be conducted? And then I would also like Ms. Abha to add to that about how it was done in Odisha, because I think that would be an interesting example for our participants to know. So over to Prushti, sir.
Thank you, Valerie. The capacity building is such an important subject and important requirement at this time of crisis. It cannot be undermined. Emphasis is always at the top on capacity building, because this has gone to the community spread. The need for our volunteers, need for our frontline workers, need for our civil society actors, our community organization, volunteers, NYK and NSS, you name, all them need capacity building. So now the question comes, how you capacity, what capacity you will build and how you will build capacity. What, in terms of what? Yes, we have got various protocols, we've got various do's and don'ts, and how you have to be safe. You know, like it's told in an aircraft, when you go, they'll say that in case the oxygen short, then the mask will fall. You first put your mask on your face and then assist your co-passenger to put the mask. So like this, our these frontline, our volunteers and our workers, they must know how to be COVID safe. That's why I was insisting on COVID safe workplace or COVID safe. So you prepare yourself. The humanitarian workers must prepare themselves first in terms of COVID response, COVID appropriate behavior and all that. And then they start telling the community. But there is no that in the first 1 year you take training, second year you will go and teach them. There is no luxury like that. We have to do it simultaneously because things are so fast unfolding. So how we'll do it? My proposition would be that the conventional method of calling people to a classroom and conducting 2-day session, 3-day session is not going to work. First of all, people will not travel. And second, that we are talking about non-contact delivery. So how we can create non-contact delivery. And thank God, we have seen that today we are in a non-contact delivery process. We are discussing, and now people are getting used to it. I have also seen organizations delivering this kind of training services to the front line. And in fact, I'm incubating mentoring one such organization who is providing the training to the ASA workers and nurses in the northeast, in Leh, kind of things. So in a digital mode, and many people say that digital mode you need internet connectivity and all that. No, there is you need some limited internet connectivity to download your training materials, and then you can cover a substantial part of the training offline. And so how these can be combined with offline and online kind of things, we can start working, and then it can go to scale. And one or two organizations, there has to be thousands of such organizations providing this training. And the second how is that online courses by the academic institution. Many of you would have known that Nimhans has started a online course with Odisha Open University. And in fact, I conceptualized this thing, and I brought both the institution together, and they signed MOU, and then the program has started since the time the first wave was there. And like that, this one institution offering some kind of training is not enough. That training need to be upgraded, training contents need to be developed, and more open learning systems must get engaged here. We have got many open universities in the country. They should come forward actively and all that. And many IT organizations, they should also come forward and support. So it is a huge opportunity, and we have the bandwidth, technology bandwidth we have, and the training contents we have, adequate training contents we have, and delivery mechanisms we have. Only we have to bring all these pieces we have to put together in the puzzle so that the training delivery is possible. This would be my proposition.
Thank you so much, sir. Ms. Abha, if you could just add to that with the Odisha model, please.
What Prushti sir just mentioned is the mechanism which was used, but also I think what Orissa government was, it actually quick started it. You know, it was quite fast. It was like responding at the earliest. So when there was a low, it was a peak time. Since then they started it. It did not anticipating the situation was something which did. Secondly, I also wanted to let everybody know that even the OSDMA came up with immediately with a website or a place for volunteers to register. And then they started taking up a lot of sessions, online sessions, rather than, you know, only just going in for sessions offline. But there were a lot of offline sessions which were done, but keeping COVID appropriate behavior in time. It could have taken a little more time. There were more sessions. So they in turn had a lot of master trainers developed. One of the questions which was raised by one of the participants was, how did they take care of the outsiders? People in the villages and other things are done, but what about the outsiders who have come there? What the government here did was also to make panchayat sarpanches responsible for any person within their villages. And in the city areas, they try to work with, you know, the contractors, the ward members and others to ensure that they also receive a certain amount of the services which is being provided to others. Specifically for the migrants, if you take it, Orissa did it well because every village had a quarantine center. Anybody coming from anywhere had to stay there, and it was maintained by the community themselves. And there was a portal where there daily the registration immediately apps, I mean, technology, leveraging technology was something which was quickly done by the government of Orissa. So most of the information about migrants and other things were also captured. Yes, a lot of people can still say that we did not capture 100%, we failed here and there. Yes, there will always be some mistakes somewhere, but there were a lot of good steps which were taken up. And today, as of today, I think they have actually mapping out all the government hospitals, the beds, the material which is available on the website, so it becomes easier for the people to monitor it and take advantage of it. And that is also the local level of government functionaries, be it on contractuals or regular officials. All of them are being engaged to collect these information. Also, information collection is also very important, and that's one where another community is the only one who can give you the correct information. And grievance redressal cells, this is something which I think is also very important. The government of Orissa actually started department wise apps as well as CMO wise at the CMO's office, that is Chief Minister's office level, a grievance redressal. And anything which was put on Twitter, Facebook was quickly followed up.
Thank you so much for those inputs. I am going to pick up from one point that you had mentioned in the beginning, is that some of this was also anticipated. And because of that anticipation, measures for capacity building and other things were taken. So in reference to this, my question will be to Dr. Santosh. Professor Santosh, are you there, sir?
Yeah,
Right,
yeah,
so
I'm there.
okay, great. Let me just, sorry. Right. So collectively, as stakeholders in this disaster management ecosystem, do you think that our reaction, we have reacted to the disaster and not been proactive or anticipated enough the kind of damage that this could have caused? And I'm talking about all stakeholders here.
Yeah, all stakeholders, if you see the first wave, we should look at the first wave. That is very important. That first wave, everybody was responding to the one central guidelines, and every state was also adhering to that, what has been discussed. And constantly there was a meeting with the chief ministers and all, constantly meeting with the civil society at the local level, the state level and all. And that could result in terms of minimum loss to the life loss to the country. But I'm not talking about economic loss and other thing, but that was the need of the hour. But now in the coming to the phase 2 or the wave 2, you can say, and likelihood of wave 3 now. So wave 2, definitely some complacency. People thought that now it has gone, kind of a thing. We said that disaster is over. Now we can breathe, and especially we can remove the mask. And the title which came up from the United States, that smiling without mask. So that kind of a situation we assumed much earlier than it is to be. So that led to a kind of a anticipation, what you said, the anticipation of risk. So that anticipation of risk was totally not there. And in that case, the government and the peoples both started their preparation, but not thinking that it will come so fast. So that took, but what happened when the second wave came, then it did not give you the time to prepare proactively, which you say. Although that earlier the government had taken decision about that, increasing the testing center, increasing the vaccination process, increasing the kind of hospital care and sanitization, mask and so on and so forth. But that was the first way for that to tackle. And this was quite strengthened during that time. But if you have mask, you have sanitizer, but you are not actually wearing that. You are not having that. Earlier we didn't have, but when we had this, then we are not wearing this. So that kind of complacency or forgetting about those kind of a situation, then it lead to a kind of what we are facing today. But still we have whatever we have lost is very difficult to compensate those as a kind of a human loss. And the family, I myself have lost my own elder brother in this COVID-19. So many of the families they have lost their own near and dear ones. and the known relatives in this disaster. But we are also side by side drawing lessons that whether the COVID or no COVID, as long as even that case when it happened with Wuhan, we started with a very limited number of cases, but it moved on to a whole of the globe. So same analogy which we are taking up this, even if it is in one village, it is left out. Even if the 10% of the villages are affected with COVID-19, there's a sure sort of a kind of taking this assumption that it will go to the pan-India as well, like that started from Wuhan and spread to across the globe. So our attempt is to bring down to almost kind of a zero kind of a infection. But by the time if we have a kind of a vaccination and it people are not allowing villagers, the medical practitioners and also that those who are giving vaccine, they are not allowed to go to the village. They are fighting their own battles, say, no, 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 you just, you will kill me and this kind of a. So here I see, sorry, the role of civil society is a very, very much important, and the panchayat very important in forming and educating people that yes, those kind of initial hiccups were there in the vaccine. Nobody knew that vaccine will behave differently. Now whole globe is getting vaccinated, so why not we also can come into that? So vaccine would be there, large number of vaccination process would be started, India being the largest vaccination, but still the minimum population covered. That's what the irony with India. So what I'm saying is that proactive engagement of the government and civil society without losing the sight of the third wave also. And we should start preparing proactively with the support of everyone, whatever the small or big lessons which we have learned at the individual level, at the community level, and also at the district level, panchayat level, should go into the form of a planning for the third wave and also fighting out the second wave as well, which is still going on. So what Dr. Maya mentioned about the rural area, that is the biggest concern, because that is multiplying quite fast and the death rate would be very high, and the affected rate ratio is also very high. We are going for the 20% to 30% to now 40%, and some villages have the 50, 40, 60% of the kind of affected ratio. So this is a concern that how to break that cycle. So that local level lockdown and village-wise lockdown kind of a thing probably would have much more control. So that empowering local community, empowering local civil society, and also having faith in the system still that we can, many of the doctors have lost their lives. So how we can think of that the system is not working, system is providing support. So we have to have a trust in the system, as Abha was telling about Orissa, the similar thing which we saw in Bihar also, we saw in Haryana also, that many of the support is coming from different community support proactively. So what I'm saying is that idea is to bring out those learnings which is happening at the different state level and the local level, and share with the other states, those who are affected, likely to be affected, like example of Kerala and Orissa and the Mairada and other examples, and some part of Haryana also brought, some Punjab also brought, Bihar also brought. So how to collate those information and that people's own initiative with the government or with the local panchayat, and how they could work. And one point which I would like to definitely mention, where it, although you have not asked me about the resources, that if that resource support is not there, it's very difficult for the community organization, community-based organization to function. So there you see that Abha raised this issue of Niti Aayog announcement, and if you see that 15th Finance Commission recommendations, where we are working about rehabilitations, large number of funds have been allocated for proactive risk reduction. And since we are dealing this pandemic with also Disaster Management Act, and I remember immediately when I got this information from Karnataka, the 26 children got orphaned. They lost their parents due to COVID. And somebody contacted me from Karnataka, Bangalore. And then I spoke to the Department of Women and Child, Joint Secretary immediately. And it was Sunday, and Joint Secretary immediately swung into action, spoke to the three collectors there, and immediately the children were taken into kind of a refuge and provided some support. And immediately that order, which was the government of India is taking actions at different levels, that was there. What are the programs and the schemes are available, which collector can actually use that for, and that civil society can also use that kind of a support system. So what I'm saying, many a times what the government is taking decisions also not percolating down to the lowest level. Lowest level of functionaries, meaning that the local level of functionaries. So that is also our challenge, that how to take this as a kind of a these learnings and also those initiatives of the various state governments, those who have taken proactively, as Abba said, that the how large number of people got trained. So similar capacity building approach can be taken by, like our child-centric disaster risk reduction, and NIDM is also trying very hard to train those health functionaries, ASA worker and all, to reach out to them for actually providing that support for capacity building. So, but still that challenge, what we say, there's a drop in the ocean. I'm not saying that it's a wonderful job, but it's a complex reality, and we have to provide our support with this kind of acknowledgement of the complex realities, and the support of the civil society, which has come at this point of time, has been commendable, and various states experiences, the local level experiences must be brought to the floor, and make it institutionalization process, so that in any disaster happens for the third wave or maybe other disasters is also happening, the learning of pandemic can also go to the other disaster, and other disasters can also go to the this pandemic learning. So we are not free from pandemic. So now today I saw that now this oxygen black patches, it has been declared as a pandemic, epidemic also by the states. So epidemic and pandemic now are combining together in many of the states. So this is also a scenario. So pandemic, epidemic, and also a disaster like cyclonic storms. So see, in this context and the cascading impact, I would be uh, any my support or NIDM support in this context, we would be extremely happy to work together from the government side, and whatever the things which you say, that is that we can take it to the logical end.
Right. Thank you so much, sir, for that reassurance. I'm going to take this one last question with Ms. Maya, because in the interest of time, we also have to open up the floor for questions. So, Ms. Maya, my question to you would be that, has community as a stakeholder, have they had to take a larger role in this pandemic than they would have generally done in response to other disasters and emergencies?
I mean, obviously, yes. And this time, especially in the second wave, just like Dr. Santosh said, that it's hit people personally, And it was in the first wave, it was not somebody somewhere there. But this time, I don't think anyone has not been affected in terms of a friend or a colleague or definitely family member. So there's been definite response. And it was said earlier, that everyone has reached out in some way or the other, whether it's students trying to do something. The IT sector has literally forgotten IT to a large extent and pushed a lot of their resources into looking at, even if it's a small app or if it is getting some resources together for oxygen concentrators. So the community has played a huge role, and that's what's got us through so far, because the government was just hit in the face with this thing. And by the time the red tapeism and all that is required of a bureaucratic government takes place, other things have come into place, whether it's even the local community and even the international community has responded. So 100%. And that just shows that we need to learn from this and prepare proactively. There is going to be a third wave. It's not maybe, there is. And there are countries that have dealt with second and third waves and shown the way. We really need to learn from those, build our institutional policies, put them in place, train the people. This is the time to start anticipating for the third wave. I already said October, so this time take the scientists seriously, and plan with a very, very specific community based response in place, and the community based is not only panchayat, it is community based organizations, it's volunteers, it's the NGO sector. Each one has a role, and if everyone is put together, we can really make a difference for the third wave.
And Dr. Maya, many of the doctor association from national and international, they have come out and they are helping and online
yes.
counseling, and
A
also
lot are doing teleconsultations. A lot.
teleconsultation could also be taken as a kind of a
Yes, as a community response. They're doing it.
Yeah, Valerie, just to interject one point I want to make at this time. Is it okay?
Yes, please go ahead.
It's very interestingly what Professor Santosh and Maya was talking and Rava was talking. If you would have heard a few days back, Dr. K.K. Agarwal was the former president of National Medical Association, who passed away. On his last video, he was appealing to the medical fraternity. He was talking that you communitize the medical consultation. He said that it is not one-to-one consultation right now. You can consult the COVID-affected community in large numbers together, and in a like he was mentioning that you make a kind of Zoom call you are making, like that you can talk to people and get their symptoms and get them diagnosed and all that. It reminded me of our the evolution of psychosocial care design. When the psychosocial design was being thought of, that time the psychiatrist community, they were telling that the trauma treatment is personal and it cannot be done in a group process and so one-to-one. But we were trying to experiment that in Gujarat post earthquake and the riot, and this was the opinion of the psychiatrist community. But then when you talk to the social psychiatrists, then say that yes, it can be done. Then we attempted that, and from there the psychosocial care concept evolved, and today you have got the whole psychosocial care training module, and there is an institution, there is a Center for Psychosocial Care in Disaster Management in Bangalore, and it has become a global model. So this has come out of that. It is from a personal diagnosis to a group diagnosis, because the cause of the trauma is common. So here is this cause of the ailment is common across a group. So the personal manifestation may be there, but the cause is, so it can be addressed together. So that is the way communitization of the COVID consultation can be possible and should be done, so that you can reach the mass. Otherwise, the number is so huge, we cannot really do it one-to-one. That is what was Dr. Agarwal's message. I reiterate that message today to you.
Valerie, just one point.
Yes,
Mr. Prushti, just for your knowledge, and I think you would be also very happy to know, when we had the OSED program, the UNDP were doing it with the USAID, sorry, OSED I'm saying, USAID and UNDP city-based disaster management plan. And Cuttack city was one of the cities which we have taken up. You won't believe it, what exactly you just mentioned, sir. The city commissioner, along with the Center for Mental Health, which is there in Cuttack city, and other doctors from SCB Medical College are actually doing that. They are having Zoom calls with COVID patients, with patients who are in home isolation, to actually do a community level, have an open discourse. Anybody has any problems, they will be immediately, they can raise it, they can get some answers, they can also be referred to. So there was this last meeting when I was there was this one person who was very much, afraid for his pregnant wife. And he got an answer, and that motivated somebody else to also share his viewpoints. So I think what Prushti sir said is very good. And there is an example, excellent example, which is taken by Ananya, the municipal commissioner of Cuttack. It's really good, and I think community way is very good that way.
Yeah. I think there are some 30 districts in India this program was implemented, 30 or 13. Cuttack was one. I think in Odisha, 3 districts or 2 districts they have
No,
taken.
no, not that one. This is the city-based program. This
Okay,
is a urban resilience program,
okay.
which is in 6 cities only, which
Okay.
ended
6
in last December. But learnings from that, Ananya is able to take it up and do a community level training.
Yeah. That is, in fact, the learning from the community, this communitization of the psychosocial care training, we can go to the COVID care diagnosis kind of thing. That was my plea. That was my proposition. Many medical practitioners may agree or may not agree, but this is what is need of the hour.
Absolutely, sir. I think that is a need of the hour. Hajil, do you have anything to add to that? To all this discussion? Otherwise, we open the floor for questions.
Sorry, I was just having some problem with my internet. I think we can open the questions.
Okay, great. All right. We have a raised hand from Mr. Premjit Bagh. I'm going to request you to unmute yourself and you may ask your question, please. Mr. Premjit, I have given you an option to unmute yourself. Okay, fine. Mr. Jay Krishna Nayak's hand is also raised.
Madam, you have taken Odisha as our case study. So my question is that what is the how we can prevent a third wave for children? How can we prevent the spreading of third wave for children? Because I am a teacher, sir, I have around 250 students. So how can we prevent the spreading of the third wave?
Okay, I think I could faintly understand the question as how we can prevent the third wave, especially focusing on children. Maybe we can also contextualize in terms of how community can support with that. And I open that to all the panelists, please.
Anyway, if it's for children and you're a teacher, you have a very big role already. You start with awareness programs now, along with your maths and your science and your other classes. Talk about, what the child can do. Today, the children are, they know about masks, but ask them if they see their parents. Children can influence adults much easier than adults can influence other adults. So just the prevention aspects, making sure that people who are sick in their home get tested. When the vaccine comes, how important it is for keep talking to your children from now on every day in your classes. Don't wait for the third wave, and you'll definitely make sure that at least the children will start looking at things and trying to influence the others.
In fact, what Dr. Maya said, that's probably the remedy. The teachers, today all online classes are going on. If the teachers take the COVID appropriate behavior and COVID response, they get themselves oriented and trained, and then they in turn pass it on to the students. It will be a great thing. I think Dr. Maya, you have hit on the point, and this is so important that need to be practiced at scale.
Absolutely. Thank you so much for that question. Also, Mr. Nayak. Yeah, Hajil would like to add to that.
So I just have an experience to share from here. So often when we give medicines to people who are sick and they refuse, we approach their children and they very readily say that, yes, we will inform our parents. So I agree with Dr. Maya on that.
Great. Thank you for that, Hajil. We have Mr. Premjit Bagh. Could you please ask your question now?
Yeah, thank you, ma'am. Good evening to all. My question will be, as we are discussing about community-based initiative for COVID-19 response here, my question will be to the esteemed panel is that if we are not able to contain the spread of the virus in the urban areas, in spite of several efforts, and the people of the urban areas are more educated and they are not behaving responsibly to the guidelines, how can we contain the spread of virus in the rural areas by taking community-based initiatives? Thank you.
Thank you for that.
Do I come in?
Yes, please.
Yeah, this is a very interesting and is a challenging point. In fact, the urban management, the COVID management in the urban space has been very challenging. And many of you would have known that when during the first wave, in many villages, there was a so moto action. Like the villagers, they decided that they will not allow any newcomers to the village. If they come, they will have to go through a mandatory quarantine in the village school, and the community will provide them food. And some NGOs, they extended even the health monitoring. Like those days, this oximeter was not there. They were saying that only the infrared screening, temperature and all that, and the information was given to the nearest hospital and all that. After about 14 days quarantine, they used to be allowed to the village. And all the villagers were advised that please do not invite any of your relations to the village during the pandemic. These are the kind of things, so moto actions started in the villages. And the community bonding at the village, rural areas is much stronger than the urban space. Urban areas, within the resident welfare association, you will have 1,000 views, and no one will support the other's view and all that. Everybody thinks that they are more knowledgeable and all that. Whereas in a rural area, there is a tendency, there is a much greater prevalence of listening to the suggestions of the elderly, suggestions of the few people, like the school teacher and all that. They command a tremendous amount of respect in the rural setting. The NGOs who have been doing excellent work, they have got acceptability, their voices matters. And their senior citizens, older people, their voice matters. So all this wisdom at the rural area can be pulled together, and the cohesive approach can really help to prevent. Like we can talk about COVID care center in the villages. We can talk about the monitoring the health conditions of the people who are suspected, symptomatic or asymptomatic COVID patients, and their health monitoring is there, and then they're provided with various services. So all these things can be done together by the local NGOs, community groups, and the panchayats, and with the help of the government. It can be done at the village level, so that we can keep the village safe. And it will be, it is not easy, but it definitely, it will be possible, which was not possible in a urban space. It will be possible in a village, because villages are smaller unit, and we can probably do that.
COVID safe village. I think that would be a lovely campaign to have.
Yeah, COVID safe village.
Thank you for that. I'm going to take the last question from the chat box, which is by Ms. Rajshri Das. She says that while we do talk about community engagement, there is also stigma associated with COVID-19, and especially so in the second wave. How can we address that through our community initiatives?
So I'd like to answer that.
Yeah.
So with our volunteers here, we do see a lot of fear about getting involved in such work, and I think with stigma, what goes best is accurate and simple information. When the person knows and understands the virus, how it is spreading, how they can keep themselves safe, how they can keep their family safe, I think that helps in removing the stigma. And our community volunteers, the youth, the children, all different ashas, ANMs, if they give the right messaging. Right now, if we see the situation, the messaging is it's complex. The messaging is not context specific. The messaging is not very clear. There's so much of information, and if this is brought down into simple and easy to understand messages, I think we can address stigma.
Yeah, I'll supplement this. One of my colleagues who is working on the CBCP, Prafulla, is he there in the group today? Aditi, you are there. I don't know. The Prafulla mentioned me something 2 days back, that the counseling must start from the time somebody shows some early signs of COVID symptoms. And that is the time the beginning of the intervention, the trauma care, psychosocial care starts. And if the psychosocial intervention counseling starts from that point, the stigma can be addressed. The person will feel much more empowered, and she'll feel hope that it is curable, or it can be handled. There are people around him, there are institutions around him, everything can be done. So he will not feel helpless, and then he will not hesitate to to disclose and hesitate to take the services and all that, because of this stigma attached to it, people even avoid the COVID interventions. Like they will not get tested, they will not get vaccinated, they will not get, because they will not tell anybody. So as a result, 5 days, 4 days, 5 days pass, and the disease becomes uncontrollable. So that is the time we should start immediately, and then gradually people will say, oh no, like malaria, people are not afraid of telling that I am having malaria. People have diarrhea, people didn't hide those things, but people do hide HIV/AIDS, and people do hide leprosy. People used to hide TB, but not so much today. And COVID, yes, people are hiding today, but gradually with our efforts, our engagement, people will stop hiding it. So
I think it is one thing I agree with Patricia that a lot of people are hiding it. It is not just because of stigma attached to the disease itself, but it is also a lot of misinformation, or also they are sidelined. I'll just give you an example. A very senior professional retired from one of the commissions uh, was tested positive. Now, the first thing in the apartment people started saying, for 14 days, nobody is going to come and pick up the garbage which is going to come. Come on, she is going to cook. Now, if there is cooking, then there is something which is going to be, has to be thrown in our dustbin. Somebody has to come in. So then, okay, then she says, okay, I'll go and put it somewhere. You cannot go out of the house because you are isolated. Now, what is the systems which are there to support them? That is also restrict. That is why this whole stigmatization is happening, because somewhere we as a community, we are not coming to support each other at that particular time. We could always have said, okay, let us have a garbage bag where somewhere we can put it properly. Now, who leaves the milk, where it has to be kept, what is to be done? I'm just talking at an urban context. In rural areas, I stay in a rural area. I am coming to an office in an urban area, but I go back to a rural area. In the rural areas, we still people still support each other, because there is a distance between the houses also. People can stay in their houses, they are not so interdependent, like for a lift or a staircase or something else. So you can have some support system, or you also have systems that you can go and buy the vegetable right in front of your household. So there are these systematic differences between an urban and a rural area. So that is where, as a community-based support system, somewhere we need to think of how do we support in day-to-day affairs of a urban or a rural infected person.
yeah, this is very excellent input.
That's actually an excellent. Thank you so much. Since we have already crossed 7 minutes over time, I won't be taking any more questions for now. So I would apologize to the participants for that. But before we end this session, I think it'll be of importance to sort of bring together the key points that were discussed today. So while we do understand that the community is sort of evolving even with this response, some of the key points that we need to keep in mind is that it is very important to right now institutionalize the processes and the learnings, so that in case of a third wave, we can implement these, we can learn from that and be more prepared. Like, for example, we had this whole discussion about anticipation. This is where that point also comes in. Second is the training and capacity building of frontline volunteers is extremely important, whether they are ASHA workers, Anganwadi workers, or even community volunteers or self-help groups. Capacity building in whatever means that we can do is essential. Resource support is one of the areas that needs a lot of work, because there is the willingness to go ahead and contribute. There is the willingness from community to respond, but there is also a lack of resources. And there were some solutions that were also offered by Professor Santosh in terms of, there are programs and schemes available, but again, this information is not available at the ground level. This information is not available at the community level, which brings me to my next point, which is that the lessons learned and these resources that we have, this information that we have, that needs to trickle down to the ground level so that most people can benefit out of it. And the last point that I would like to take up is that information sharing in clear way is very important also to combat the stigma that exists with this pandemic. So that is the summarization from my side. If I have missed any of the valid points, I would like the panelists to, just fill in for me or give any parting comments that they have. And after that, we close the session.
No, I think you have summarized very well, and the inputs provided by all the panelists were excellent, and I have noted most of the things. And the concept is community-based COVID preparedness program model framework that I'm working on with my colleagues Prafulla and Aditi. I think this discussion today have got tremendous input, and we will come with the version 0 and share with you all, and for further critique, and see how we'll be able to institutionalize, how we'll be able to build into it the program that all of you told, so that we were able to really face the third wave effectively.
Right.
And together.
So we should, I think, avoid duplicating. The NITM is also working on the same thing which you are working.
Yeah, we'll work together. We'll work together.
We should combine the effort.
Yeah. Always.
So we can have a joint work.
Yeah.
And we can the maximum benefit community should get out of it.
Absolutely.
Great to see this collaboration coming. That is also one of the agenda of this.
We are original collaborators, Valerie.
Thank you so much. And I would also like to extend a special thanks to NITM for their support in bringing this session together, since this session was conducted in collaboration with NITM. With that, once again, I would like to thank Professor Santosh, Mr. Prusti, Ms. Abha, Ms. Maya, and Hejal for all your inputs, for taking the time out between your busy schedules and talk with our volunteers about this. Thank you so much. And thank you, Siljo, for all your back-end support with this. And thanks to Ali from NITM as well. Thank you, everyone. And please have a great weekend and stay safe.
Thank you.
Thank you. Bye-bye. Thank you, Abha. Thank you, Maya. Thank you, Hejal. Thank you, Valerie.
Thank you all.
Thank you, Professor.
Thank you to the participants
everybody.
also.
Yes,
Thank you all.
Listening
Thank you.
to us.
Bye.